Good morning. Today I want to talk about optimal PEEP in a really practical bedside way. Not all the PEEP math and details, but what you can know and learn to quickly figure out what a good PEEP is in a patient in the ICU or in the operating room. So when I teach PEEP, I've learned that in training, all of us have this idea that PEEP is for FiO2. And this comes from all of the ARDSNet tables that teach you that per FiO2, you should escalate your PEEP. And those aren't bad, but they're starting points and you should adjust from them. Really, we don't do PEEP for oxygenation in and of itself. It has an association with improving oxygenation, but we do PEEP for compliance. And it just so happens that when you optimize compliance, you've recruited the most recruitable lung that you can, and your oxygenation gets better. We saw this in COVID, where early COVID would have very compliant lungs and need very little PEEP, yet be very hypoxic. And as things progressed and the lungs got sicker and more scarred down or injured, they would need more and more PEEP, and the oxygenation would still be severe. So we don't do PEEP for oxygen in and of itself. We do PEEP for compliance. And compliance math depends on the ventilator mode that you've picked. In pressure control modes, you're going to get more volume because the pressure is set by you and volume is the variable. In volume control modes, you're going to get the same volume for less pressure. So a lower plateau minus your PEEP pressure, or lower driving pressure. And PRVC, PCVVG, or smart pressure control, all those modes that have different names based on the brand you picked, you get a lower pressure that the vent sets because it's just smart pressure control. So if you target a tidal volume of 500, the vent will give less pressure to get there. So when we go to the bedside and say, hey, am I on the right amount of PEEP? Should I go up on PEEP? The first step is to figure out what the starting point is for your compliance. In this example that I've shown here, we have PCVVG or PRVC mode, and I have targeted a tidal volume of 425, and the vent is delivering 15 over 5, right? So 20 minus 5 is a delta or a driving pressure of 15. So the vent set that driving pressure to 15 to achieve that, and that's my compliance. In a pressure mode, you'd look at how much volume you're getting for the pressure you set. And in a volume mode, you'd look at your plateau minus your PEEP, or the driving pressure for the volume that you've set. So first step, look at your compliance. The second step is to make an adjustment. You're going to pick a new PEEP, and then you're going to do a mini recruitment. Mini recruitment you have to apply cautiously because it might decrease the amount of volume getting back to the chest. So in preload dependent patients, this could be harmful. And it does increase afterload on the RV. So patients with pulmonary hypertension, hypercarbia, or RVs that struggle aren't going to tolerate that well. And it definitely decreases the venous drainage of the brain. So intracranial hypertension is another patient population where you might want to apply recruitment maneuvers cautiously. But it's important to remember that recruitment maneuvers are not all the same. A pressure of 30 for 20 to 30 seconds is not bad and really tolerated quite well. Going higher than that, you run into some different risks. Going a lot higher than that, you run into very real risk. So a little gentle recruitment maneuver is appropriate. If you change the PEEP and don't do a recruitment maneuver, you can expect the PEEP to adjust and to recruit over hours and hours and hours. That makes it hard to know your optimal PEEP. This stuff takes a long time to make a difference at the patient level. So if you want to know at the bedside, change the PEEP, do a recruitment maneuver, and then move on to the next step. So for this example that I showed, the first starting PEEP was 5. I've made it 10. We assessed our compliance. So previously, the driving pressure was 15. So it was a P high of 20 over a PEEP of 5 for the same tidal volume here, 425 milliliters. We changed the PEEP from 5 to 10. We did a mini recruitment, and then you let it stabilize and ask yourself, did it help? So how do I know if it helped? I go back to step one and I reassess my compliance and ask if it got better. It's pretty straightforward. Here, we know that the driving pressure went from 15 to 12. So I got better. A PEEP increase from 5 to 10 did good. So again, you start by assessing your compliance. You figure out your driving pressure or the volume you're getting for your set driving pressure. You pick a new PEEP mini recruitment maneuver and you ask if compliance got better. If it's worse or not better at all, you're adjusting between optimal PEEP and moving towards being overstretched. If things got better, you consider, did it get a lot better? Do it again. Go up even higher on your PEEP. If it got a tiny bit better, you may be at the starting level of your optimal PEEP, and you have to make a judgment call. Do you want to be on the high end of optimal PEEP or on the low end of optimal PEEP? And you make that decision based on the physiology of the patient in front of you. Here, our old vent settings were on the upper right, and here, our new vent settings are down there. So I went from 5 to 10. My driving pressure went from 15 to 12. That's good. And so now I went from 10 to 14 on my PEEP. So from 10 to 14, I applied a mini recruitment maneuver. I waited and I asked myself, did this improve my compliance or not? How do I know? I look at my driving pressure in this mode of ventilation, PCVVG or PRVC, smart pressure control. Here we are, PEEP is 14, my total pressure is 26, my driving pressure is 12. Well, that's the same as I was before. So I went from 10 to 14 with absolutely no change in my compliance. That tells you your optimal optimal PEEP range. And you can decide, do you really need to avoid any atelectasis and hope to recruit a slight amount of lung over time? Maybe you need to improve your oxygenation or the patient's at risk of de-recruiting for one reason or another. Or do you want a lower end of your PEEP threshold for optimal PEEP, where you might have a patient with a sicker RV who needs optimal drainage of their cerebral veins, or who's very preload dependent, bleeding out, or otherwise you're trying to run them really dry. You may want them to be on the low end of your optimal PEEP and avoiding any sort of pressure injury. So that's how you decide between 10 and 14. In this case, you might split the difference and go to 12. There are a handful of fantastic reads. These 3 studies that I've shown here aren't really studies. They're more editorial commentaries that cite all the science stuff, but apply it to the bedside in a really effective way. My favorite one is the top left one, How I Do It, Setting and Titrating PEEP by Dr. Millington and Chest. The 10 rules for optimizing ventilator settings post-cardiac arrest really focuses a lot on this as well in a really effective bedside way. And the bottom one is another fantastic article by Dr. Neiman in intensive care medicine that really focuses again on personalizing the ventilator to the patient in front of you. A little more science driven, which I love. Good way to nerd out. And that's it. That's how you optimize PEEP at the bedside. Happy ventilating.